Hello, I'm Dr. Donald Geriatric. I'm a professor of geriatrics at the University of North Dakota. Today, I would like to do a presentation on geriatric assessment. This is brought through the HRSA funding program for the Geriatric Workforce Enhancement. Our program is called Dakota Geriatrics. The objectives for this session is to identify with whom and when to conduct comprehensive geriatric assessment. Included in this is the assessment of functional ability. I'd also like to cover the performance of rapid geriatric screening, as well as to conduct comprehensive geriatric assessment. And then we'd like to talk about routinely applying what we call the geriatric 4Ms, and also to identify the rationale behind geriatric assessment, including its both economic impact as well as health outcomes impact. And I just added this picture of a windy road going to the horizon here with the setting sun, somewhat of a metaphor for geriatrics, that in the latter part of life, represented by the setting sun, that we have somewhat of a windy and twisty road to understand the aging process. And so geriatric assessment is part of that process that we hope will clarify goals and plans of care for the last part of our lifespan. The topics that we're going to cover today are the principles of geriatric assessment. We want to look at the different elements listed there, with the physical through functional status elements of the exam. We also want to talk about the acute functional decline, usually that occurs after a hospitalization. And then we'll spend a little time talking about quality of life issues and how that might be measured in the clinical setting. So, some of the principles of geriatric assessment is that they can be applied at all sites of care, so across the continuum of care, outpatient setting, nursing home setting, assisted living, right on through hospital-based care, both medical and surgical units. This is performance-based, and so the assessments can be developed through self-assessment tools, informants, such as a caregiver or family member, and through direct observation by the clinical provider. The approach towards geriatric assessment can be a screening type operation where it's targeted, and if there's a screen positive result, you can then do a deeper dive. Also, as these assessments are being done, ideally you would like to do them at one time, but you can also apply a rolling type assessment program where, for example, you do a fall evaluation with one clinical visit, and then perhaps 3 to 4 months later, you do cognitive assessments. So the question is why you would even want to do geriatric assessment. And part of the reason is that geriatric problems are common, and importantly, they're under-recognized and often inadequately assessed and managed. And I'll give you a few examples here. So research shows that 85% of older adults with cognitive impairment go unrecognized. This is an audit of numerous primary care practices, and also in hospital problem lists, you very rarely see cognitive impairment. You don't see delirium listed as on the problem list. Also, in other areas of geriatric syndromes, the study found that only 10% of primary care providers actually ask if their older adult patient fell. And if they do, only a quarter of them actually document the fall. So we come to understand geriatric assessment as an opportunity to improve the recognition of geriatric syndromes. It also helps us through that recognition, to improve management, either to prevent something like a fall or to prevent memory loss, actually, as well as delay complications that might occur. So if you have somebody that falls, you want to protect them from a future fall with injury. And then overall, the idea of geriatric assessment is that it improves what we call the healthy lifespan. So we want to ask, does geriatric assessment actually work? And so you can ask that question both from a health outcomes point of view in terms of better health, better care, but if you have a business inclination, you might ask, does it lower costs or actually generate additional revenues? So where does geriatrics fit in to the healthcare system, both hospital-based and outpatient-based programming? So there's a series of reports, and this is just a smidgen. There's hundreds of studies. Okay, so I just wanted to give some more recent examples of reports that show that you can achieve higher quality care at lower costs through a geriatric consultation service in the hospital. So you can see in the right-hand column, the outcomes of this study showed over $600 less costs per day per patient. There were more patients discharged to home. And as a result of geriatric consultation, the individuals were exposed to fewer unsafe medications, typically the anticholinergics, the benzodiazepines, and other medication classes that we'll talk about. The second row of this table shows that there are economic benefits additionally to doing geriatric assessment. So on a med-surg unit, there was over 1 full day of reduced length of stay in the hospital. And importantly, there was a lower mortality rate. The odds ratio was lowered to 0.78 as a consequence of geriatric evaluations. And then there are long-term benefits from geriatric assessment, and one study found that over a 3-year period that there were lower bed days of care, and we'll see shortly how that fares out in other studies. In terms of outpatient operations, comprehensive geriatric assessment increases the QALY metric, or the quality adjusted life years. It also impacted primary healthcare costs. Home-based comprehensive geriatric assessment was found to prevent functional decline. And in another study, it impacted the mortality rate and also reduced long-term care transfers. A program at Sanford Healthcare System called the Fall Prevention Clinic had an impact in one of the years of the program of reducing falls in older adult patients that were evaluated by 50%, which is pretty significant relative to community-based studies, where the best that those studies can do is reduce falls by 33%. So with the eye towards business, or does geriatric assessment cost anything? Well, the answer is yes, it does cost, but in the long run, you've got examples here of cost savings. So one study from Hartford Hospital in Connecticut saved $96 million over several years on delirium prevention. More recently, Rush Medical Center applied the geriatric 4Ms throughout their system with over 20,000 patients evaluated, and their hospital length of stay was reduced by one full day. When programs evaluate the return on investment in outpatient geriatrics, there's various findings ranging from, in this case, 115% return on investment, and others have found larger returns on investment. And a lot of that is based upon whether they're an accountable care organization, fee-for-service model of care, or a combination of both. So one of the questions becomes, what counts as a geriatric syndrome? And so you can see the list here of different geriatric conditions: frailty, failure to thrive, so that's adult failure to thrive, falls, dizziness, loss of muscle mass such as sarcopenia, And some people believe that you have both bone loss and muscle mass concurrently. Big one, obviously, is cognitive impairment. 10% of all 65 and older individuals have some form of cognitive impairment. And then fatigue that often goes with frailty, sensory deficits, and then disruption of our biorhythm that leads to sleep disorders, if not sleep apnea. So who should we refer for comprehensive geriatric assessment? Well, there's 3 ways you can look at this. One is to target specific populations. So you could have an age cutoff. All people 75 and older get geriatric assessment. That would be a pretty fair way to do it. You could look at the number of medical comorbidities. So we know that 1/3 of the older adult population has one or no comorbidity. But on the other hand, 1/3 of them have 5 or more comorbidities. So if you identify somebody with 5 or more chronic conditions, that might be the basis of a referral for geriatric assessment, and so forth. In terms of change in status, this is an important metric. Hospitalization is often the bellwether for change in functional status, and it really depends on whether the patient had a functional impairment before they were hospitalized or not. So if you had a functional impairment before hospitalization, there's an 85% chance that you're going to acquire another functional impairment. So again, hospitalization in of itself is a marker for referring geriatric assessments. And one of the points that I think is emerging is slow gait speed. So people that have gait speed of less than 1 meter per second have multiple risk factors for falling, hospitalization, cognitive impairment, and death. So those 4 parameters themselves are marked by a simple test that can be done in less than a minute in the clinic to identify older adults who would benefit from geriatric assessment. So there's actually multiple stakeholders who benefit from geriatric assessment. Certainly the patient, who might achieve better function, both in terms of physical, cognitive function. I can't tell you how many stories we've had where we've withdrawn or suspended certain medications, either anticholinergic or opioids, where the individual suddenly wakes up or gets rid of their cognitive cloud because of medication-induced cognitive impairment. And this is all part of the work of geriatric assessment. In terms of the caregiver, there's improved satisfaction uniformly. When caregivers are asked, how did geriatric assessment go? They all have a higher level of satisfaction. If you happen to be a healthcare administrator, getting those Press-Ganey scores can be so important. The caregiver also benefits by obtaining a stronger skill set for how to manage particularly the memory impaired patient. And then in terms of the clinician, some of the metrics that are met are, for instance, if you are in a managed care program, geriatrics helps those clinicians reduce acute care. Geriatrics also reduces future hospital recidivism, reduces future length of stay, also acute care use such as emergency department use. So there's a variety of clinical strategies for identifying older adults who would benefit from comprehensive geriatric assessment. In primary care, I advocate gait speed, and this is what we're implementing in the clinic that I'm associated with. And anybody that has a gait speed of less than 1 meter per second will then get referred to the geriatric assessment program. Another way to identify older adults for comprehensive geriatric screening is to perform assessments around the 4 M's. So that's what matters, medications, mobility, and mentation. And if any of those tests are screened positive, a referral to geriatrics would be warranted. In terms of hospital screening, again, you could just use age as a cutoff. Some people have a readmission score, and so a high readmission score would also prompt geriatric assessment. And then also identification of specific diagnosis. So if you have somebody that comes in with failure to thrive syndrome, cognitive impairment, delirium, fall history, any number of those findings would and should prompt a geriatric assessment consult. So how does geriatric assessment occur? Generally, it's provider initiated, so advanced nurse practitioners or family medicine internists or even a geriatrician can advocate for geriatric assessment. It typically is multidisciplinary based, although I do know of some geriatricians that do the whole shebang themselves. It's best when applied through a multidisciplinary team. The geriatric team ideally consists of a geriatrician, a nurse practitioner, pharmacist, physical therapist, social worker, and dietitian. That's a pretty strong team. Others can be added to it, such as a chaplain, occupational therapist, and a number of other health disciplines. And the other point is that geriatric assessment tends to be lengthy. I think the best I've ever done is 90 minutes for a comprehensive geriatric assessment. Oftentimes it goes into 2 hours. And so it raises the question of whether you want to do synchronous team evaluations or asynchronous evaluations. So the synchronous would be all the team members gather in one place, evaluate the patient as a handoff from discipline to discipline, whereas the asynchronous evaluation would be each person will see the patient on perhaps a different day or time during the day when they come in for their geriatric evaluation. So the components are comprehensive for geriatric assessment, ranging from testing memory and mood down in the bottom here, as well as nutritional status. How are they doing in their environment? Are they living alone without much social support, which would be the next value? But then the big element for all of geriatric assessment is functional status, and we'll talk quite a bit more about that as we go along. Yeah, so you want to really watch out for bias in geriatrics. This poor soul that we see in the picture is just astounded by all these issues here that we see. Ageism, for example, that the patient attributes their problems to old age. Okay, old age is not a disease, so that's an important consideration. Nihilism. Patient would rather not know whether they've got memory impairment or not. They just sort of want to avoid that because that may mean nursing home placement. There's the illusionary part of that, geriatrics, that where you have over expectations of particularly of lifespan. You see this in patients who have been interviewed for heart failure, end-stage heart failure, end-stage terminal cancer. They uniformly always think that they have more life expectancy than reality would dictate. It's usually twice as much to 3 times as much, and family members often share that. So if you have somebody that's terminal with no more than 6 months of remaining life expectancy with heart failure, typically they'll report that they think they have 2 to 3 years yet to live. So the other parts of bias in geriatrics is the what I call the controller. Those are typically a family member who's taken charge and will often be the spokesperson for the older adult who may be frail, who may have cognitive impairment. And so it's always important to remember autonomy, even in the face of cognitive impairment, that you allow the older adult to speak for themselves. And then because of dementia and cognitive issues, you have biases that occur when the older adult defers questions to their family member, and you get that family member's impression through their own filter and may not necessarily reflect the older adult's point of view, either prior to a cognitive impairment or even during their dementing disorder. So comprehensive geriatric assessment has several steps. Firstly, it involves an assessment collecting data, and we'll talk about all the data and the domains with which we collect that data. It typically leads to a team meeting where everything is discussed in an interprofessional manner. There's a whole literature about leadership in team meetings in geriatrics and the parsimony, if you will, that occurs during team meetings. It's not the doctors or the geriatrician sitting there making pronouncements. It's more of a collaborative approach, and oftentimes the physician member is quite honestly the least important of the team for generating a treatment plan. So once that treatment plan is created, it's given to the older adult, possibly to their caregiver with permission. And we do have family meetings to talk about that treatment plan. So there's a post-assessment family meeting. And then the plan is implemented, and it should be monitored afterwards. And so we get feedback from the patient and from the caregiver or family member as to how things are working. And so that allows for follow-up and revision of the geriatric assessment. So I want to talk a little bit about the history of present illness and review of systems and the physical exam as applied to the older adult. And these principles are based both in terms of regular clinical encounters as well as during a geriatric assessment program. So some of the key elements to think about in terms of the review of systems, it's always important to focus on neurosensory losses, so vision and hearing issues. Sometimes there's self-reporting of hearing issues. Just be aware that older men typically don't report hearing loss. It's a little bit more insidious, and they may not just actually be aware of that. You also want to ask about falls and, importantly, fear of falling, because it turns out fear of falling is an important risk factor for future falls. In terms of driving, are you still driving? Have you had any near misses, accidents, citations, or has anybody complained about your driving? That seems to be a big one. And then also, are you using any assistive devices regularly or intermittently, or do you even have an assistive device? A lot of times I'll ask older adults about whether they have an assistive device in their residence, and they say, oh yeah, I've got a walker, but I never use it. So that's an important question. And then I think really a key question during review systems is if you got into trouble or if you had a problem, who would be your go-to person for help? And that will reveal a lot as to whether you identify what we call the Lone Ranger, who has no social support systems, versus somebody who says, oh, I'd call my daughter if I'm able to, or I've got my lifeline device here. Some of the other questions that we want to ask the older adult is whether they're doing okay financially. I had an older retired lawyer who had an amazing career, who basically his annuity ran out at the age of 90. And so from his 90th birthday on, he was basically converted to Medicaid and was financially destitute. You also want to ask older adults about any urinary problems, frequency, nocturia, and so forth. Ask them about fatigue, particularly if they are walking. Do they get tired while they're walking, short of breath? And then also sleep issues. How soundly do they sleep? Do they have problems getting to sleep or maintaining their sleep? A really important issue in geriatric assessment is to identify what matters to the older adult, and that drives just about everything else. So at the very basics, you would want to identify if they have any form of advanced directives. And mostly around the country, individuals will fill out a physician order set for life-sustaining treatment, or the so-called PULST. So that's important as to whether they've done that. But that's more for acute care problems, as well as the do not resuscitate status. In the nursing home, everybody always wanted to know if a patient got into trouble, what was their DNR status? Well, that's important at the moment of a urgent condition, but probably more importantly are things about what really matters to the patient that can be generated from, for instance, from the Stanford letter project. So the Stanford letter is pretty much a guided essay that the patient writes and describes things that are important to their life, such as taking care of a grandchild or seeing their grandchild or perhaps traveling. So if somebody says, I love to travel, I want to keep traveling, your focus on functional mobility and any impairments they may have with either pain control from arthritis or lack of mobility would be an important issue for them to consider during their geriatric assessment. Medication review is vital in the geriatric assessment. You want to understand both what they're taking as prescribed medications and reconcile that medication list, but as importantly, to understand what their over-the-counter medications are and herbal medicines, and whether they're actually trying medications from somebody else, from their spouse or a friend. You want to recognize polypharmacy, so that would be 5 medications or more. And if you can establish how adherent they are, so a lot of times if they're not using a pill box to sort their medications, there may be some adherence issues. And then just going over what we call a brown bag assessment is to take each medication and ask them, what is this medication for? And then to have them identify whether it helps them or not. A good example would be gabapentin, used for paresthesias or pain management. And many times when I ask the older adult, they kind of shrug their shoulders. They say, I'm not so sure it's helping. Okay, so that would be a inroad into further medication review and management. There are tools of assessment, and so the two that are most known, I guess, or most used are the American-derived Beers list that was derived back in, I believe, 1991, and by a geriatrician by the name of Dr. Beers, not the drinking beers, but the actual Dr. Beers. And then a European-based, I think this was started in Ireland, which is called the Start-Stop program. And here's an example of some of the stop criterion for possibly inappropriate medications or potentially inappropriate medications. You can see here proton pumps inhibitor, aspirin with no history of any vascular symptoms. Big one is benzodiazepines and so forth. You can see that there's a whole list of different medication types that would be potential opportunities for discontinuing in the older adult. A little bit more extensively is the Beers criterion, which has been adopted by the American Geriatric Society as the go-to tool. You can actually get this from the American Geriatric Society. It's a pocket tool, and it's somewhat of a category of different classes of medications. It also talks about specific health systems or organs, I meant. So, cardiovascular medications, for example, would be reviewed as some of them that are adverse. Bottom line, in cardiovascular problems or medications that cause problems are when you have a combined alpha blocker and a beta blocker, that causes a lot of issues with syncope and orthostasis. So one of the axioms in geriatrics, for instance, that's represented in the Beers criteria is to avoid combination therapies that have alpha and beta blockade. The other assessment that we do includes the basic ADLs. And so you have things like toileting, feeding, transferring, grooming, dressing, and so forth that need to be evaluated in terms of whether the individual older adult needs assistance, either minimal assistance or maximal assistance for any of these functions. We also want to review the instrumental activities of daily living. That includes shopping, the ability to use a telephone, housekeeping, transportation issues. Can they get around? Do they cook for themselves or do they have meals prepared? Whether they can do laundry, whether they sort and take their own medications, and whether they can conduct their finances. So there's somewhat of a pecking order of these instrumental ADLs that decline with either increasing age or with cognitive impairment. And I think most people find that with memory loss, that finances really become one of the key issues. So in terms of the functional status for a population, you can see that at a certain age, everybody is 100% able to do all of these functions, but that over time, that individuals lose their ability to function fully on their own, and they may enter into a phase of what we can see in this gray zone of frailty that then transitions into frank disability. And the goal of geriatric assessment is to move these arrows, this purple scale or this blue scale, up to a higher level of capacity. So this slide here shows that for instrumental activities of daily living, that there are different trajectories that occur with different diseases. And so you can see in this dark blue, the cancer, as it progresses, can have a very precipitous decline in functional activities. Also, acute hospitalization can lead to a sudden drop in activities of daily living and also instrumental activities of daily living. And then you can see with the orange line, the orange dotted line, that there's an undulating roller coaster type effect, where, like heart failure is classic. People lose their function with an acute exacerbation of the condition, and then they get better, but not quite as much as they were before. And then they have another acute exacerbation, and their function goes down. And so it goes in a sawtooth fashion. Individuals that are frail, as seen in the green graph here, also have an undulating course, but it's more of a steady drumbeat of a decline that ultimately results in death. And of course, the dotted blue line here represents that 6-month period where hospice might be an important intervention. So as we do our geriatric assessments and getting more towards the physical exam part, we want to, again, focus on neurosensory changes, both vision and hearing. And so it's important to ask about how people do for everyday tasks. Are they driving? Have they had any issues? Do they limit their driving to just the daytime? How about watching TV? Can they hear the television? Are they using captions, closed captions or not? And what about reading? So that ends this first part of geriatric assessment, and we will proceed with another session for part 2.